My absolute pleasure to introduce our speaker today, our own Dr. Erin Osterholm from the Division of Neonatology. Dr. Osterholm's training and professional career, which was rooted and then flourished right here in Minnesota, has had many, many highlights. To name just a few, she was a chief resident in our residency program in 2007. She's been named a top doctor by Minnesota Monthly consecutively for the past 7 years, as well as top Doctor Rising Star by Minneapolis St. Paul Magazine in 2015, 16, and 17. And as the medical director of the University of Minnesota Masonic Children's Hospital, NICU, she has distinguished herself as a truly inspirational leader of our group as we've expanded and improved our services to infants and their families in Minnesota over the last several years. On the research side, Dr. Osterholm has also distinguished herself. Her research program is broadly focused on understanding the impact of neonatal CMV infection on health outcomes with an eye toward prevention and treatment. She is currently a co-primary investigator with Mark Schleiss on a CDC grant that seeks to assess the impact of congenital CMV infection on infant neurodevelopment, as well as a co-investigator on an NIH-funded clinical trial of valganciclovir to improve hearing in CMV-infected infants. With that, I want to thank you, Erin, for sharing your expertise with us today, and we're very much looking forward to your talk.
Thanks, Cheryl. I really appreciate that welcome, and I really appreciate the opportunity to be here today and present our research to all of you. We'll be talking about advances in cytomegalovirus infection in the newborn today, about screening, at-risk populations, and long-term outcomes. I have nothing to disclose, but do want to thank our funding sources for this work as listed below. Today, our objectives are to discuss the varied presentation and classifications of congenital CMV, evaluate the pros and cons of a universal screening program for CMV, learn about the potential long-term developmental sequelae of that infection, and recognize the importance of postnatal acquisition of this infection in at-risk populations. In terms of some background, congenital CMV is the major infectious cause of congenital anomalies and hearing loss in infants. The majority of maternal infection and transmission is clinically silent, and current treatment options for congenital disease do not eliminate those sequelae of infection. Diagnosis of this infection at birth can be missed by clinicians on a regular basis. We'll start with a clinical case to frame up this discussion. This was a case of a 21-year-old mom, a G2P1, who had a 2-year-old at home and was noted to be measuring large for dates at 31 weeks gestation. She had an ultrasound performed, and it was noted that the head circumference was actually lagging, the lateral ventricles were enlarged, and she had moderate polyhydramnios to likely explain the large for dates measurements. She was sent for a level 2 ultrasound where they confirmed bilateral mild ventriculomegaly and a lagging head circumference, but not quite meeting the definition of microcephaly. Here is the ultrasound that we saw increased size of the lateral ventricles, so consistent with ventriculomegaly. And then this is a fetal MRI. So an MRI, so from some point of reference, the maternal habitus outside and then inside the uterus here, highlighting the infant brain. And the fetal brain was noted to be small for age, diffusely undersulcated with severe white matter loss, and dilation of the occipital and temporal horns consistent with ventriculomegaly. She underwent some lab evaluation, which found that she was susceptible to toxo, had a negative RPR, did have an IgG positive for CMV, but an IgM was negative, and had non-invasive prenatal testing, so screening for genetic trisomies that did not detect any abnormality. I was noted to have a male fetus. She had an otherwise uncomplicated pregnancy course and underwent induction of labor at 39 weeks with an uncomplicated delivery. In the NICU, the infant was noted to be small for gestational age, measuring at only the 3rd percentile with an OFC at the 2nd percentile. Did appear clinically well and quite vigorous without need for resuscitation, but was noted to have some lab abnormalities, including mild thrombocytopenia and leukopenia. Was feeding well after just a few days, And then the urine CMV PCR returned at greater than 9 million copies of CMV. ID was consulted and the infant was started on valganciclovir. And on audiology follow-up, this infant was noted to have severe mixed hearing loss on the left while passing on the right. The postnatal head imaging confirmed significant abnormalities of the CNS system. The infant was microcephalic with colpocephaly and pachygyria, so abnormal folding of the cortical structures in a constellation of findings consistent with congenital CMV, and most notably the periventricular calcifications or bright spots that we see classically in congenital CMV infection. Congenital CMV, we know, is the major infectious cause of hearing loss around the world, but the seroprevalence really varies widely between different geographic locations. Within populations, there's an age-dependent rise and correlates with race and socioeconomic status. About 50 to 60% of women in developed countries are already seropositive. And then 1 to 3% develop primary infection during pregnancy. Transmission rate to the fetus in primary infection is about 30 to 40%. Transmission rate, however, if you are already seropositive and get reinfected, is upwards of 1% in all pregnancies. So to frame this up, in 1,000 pregnancies, a lot of people think about infants acquiring CMV if a mom is seronegative. But that really represents about 40% of the population. And out of those 400 negative moms, they will have a rate of acquisition of infection somewhere around 2%, meaning that 7 get new CMV. And with that 40% transmission, 2 to 3 infants will be infected with CMV. However, it's important to note that 60% of moms are already seropositive. And so even if just 1% of those moms get reinfected with the variant strain or considered reactivation, 6 additional newborns will be infected with CMV. It's actually even a higher number than those from the seronegative moms. We do see a trend toward more serious infection in the primary acquisition, but important means of acquisition for both. The overall incidence of congenital CMV from that primary and non-primary maternal infection is 0.4 to 0.8% of all births in developed countries. Only about 10 to 15% of infants with congenital CMV present with symptoms at birth. So this has been a point of needing clarity throughout those doing research and understanding in congenital CMV is what defines symptomatic infection and what do we do with the various forms of infection. So this is from the International Congenital Cytomegalovirus Recommendations Group. It's a consensus statement published in The Lancet in 2017 and really tried to help highlight what should the definition be for moderate to severe cytomegalovirus, mildly symptomatic disease, asymptomatic disease, but does have isolated sensory neural hearing loss, and then completely asymptomatic disease. And these are all important categories that help us define at this point who we treat for symptomatic congenital infection and how we follow those patients going forward. The classic signs and symptoms that we're looking for in someone with congenital CMV infection that's symptomatic would be intrauterine growth restriction, thrombocytopenia or petechial rashes, splenomegaly, hepatomegaly, hepatitis, CNS involvement, including the intracranial calcifications and microcephaly, chorioretinitis or other ocular disease, sensory neural hearing loss, or other detection of CMV in the CNS. This is the classic images that we see in the Red Book from the American Academy of Pediatrics, highlighting the splenomegaly and the hematopoietic rash that can be seen in extramedullary hematopoiesis, as well as the periventricular calcifications classic on CNS imaging. This is an image of chorioretinitis at the ocular disease, and then just highlighting the importance of sensory neural hearing loss. So who do we treat in terms of, and how do we treat them when infants have congenital CMV? So infants with symptomatic disease, meaning they're diagnosed less than 21 days of age, they have a positive CMV PCR, and they have end organ disease, and particularly CNS disease, also including that hearing loss, undergo treatment for CMV. Generally, asymptomatic infants with no CNS disease do not get treated with antivirals, that is evolving. And antiviral therapy is not routinely recommended if you have isolated sensory neural hearing loss. We are currently part of a multi-center trial that's looking at this in a randomized fashion called the Valier trial out of the University of Utah. That's really evaluating whether antiviral therapy may be helpful in isolated sensory neural hearing loss in these patients. Why do we treat babies? We have found over time that treatment for symptomatic infection with IV ganciclovir for 6 weeks prevented hearing deterioration at 12 months. Initially, these treated infants had improvements in developmental delays at both 6 and 12 months of age compared to the untreated. Then in 2015, about not quite 15 years after initial studies, there's actually a large randomized controlled trial that compared 6 weeks versus 6 months of oral valganciclovir treatment in symptomatic infection. And although there was no change in hearing outcomes at 6 months, there were significant improvements in hearing at 12 and 24 months. These were also associated with improved neurodevelopmental scores at 24 months on Bayley scales of infant development. And as expected, notably the language composite and receptive communication scales were improved when hearing was improved. So at this time, there was a shift towards treatment towards 6 months of oral valganciclovir in symptomatic infections. And we do see that oral treatment has significantly less short-term side effects than the IV formulation. There are still potential risks to this therapy. Short-term toxicities include neutropenia, which can be quite significant, thrombocytopenia and hepatotoxicity. And really the long-term toxicities are still somewhat unclear. In some animal models, there's been concern for potential fertility impairment, especially in males. And it really does require side effect monitoring throughout the duration of therapy with regular checks of CBCs, liver, and renal function. There have been some consensus guidelines about how to evaluate during and after treatment from the International CCMV group, and really do recommend checking an ANC at least weekly for 6 weeks and then monthly for the duration of therapy with liver transaminases at least monthly, eye exams, audiology testing, and developmental assessments. So that brings us to clinical case 2, which highlights something a little less obvious than the classic congenital CMV with symptoms. This was an infant born at 36 weeks gestation, was noted to be growth restricted on follow-up ultrasounds and had some echogenic bowel, but notably at birth was not small for gestational age and actually plotted out at the 30th percentile. No evidence of hepatosplenomegaly, normal lab evaluation, passed the hearing screen. However, someone elected to send the urine CMV PCR due to the history of lagging growth on ultrasounds, and it returned with 6 million copies in the urine. So this infant would meet the definition of asymptomatic congenital CMV, meaning diagnosed by detection of DNA via PCR in body fluids, including urine, saliva, blood, or CSF, prior to day 21 of life, which really defines congenital infection. And 85 to 90% of newborns with congenital CMV fit into this category with few or no signs or symptoms of infection. The really important caveat is that, however, 15% of these infants can develop sequelae, particularly the sensory neural hearing loss that we see as a major sequelae symptom. There's no great predictor of which babies will develop the hearing loss, and routine universal screening remains a matter of debate in these infants. So as we have embarked on studies looking at screening, which I'll talk about in just a moment, we've realized that asymptomatic infection is far less clear than we previously understood. There seems to be much more of a spectrum between symptomatic and asymptomatic, and the true diagnosis differential seems to be much less clear. Some we previously thought would be symptom-free have now been identified with abnormalities over time, and the long-term sequelae in these babies really remains uncertain. So that brought us to some of the questions in the universal CMV study that we have been undertaking here at the University of Minnesota. And first, backing up just slightly, it really asks the question, should we include congenital CMV to any sort of universal screening panel, and including the rest, the standard newborn screening recommended uniform screening panel? And on one side, we have the pros looking at why we would think about screening all infants for CMV. We do have the diagnostic evaluation that can be completed if we know about this infection. Anticipatory monitoring can be undertaken more closely, especially with added services should we identify any abnormalities. We know that the hearing loss may be delayed and progressive in nature, and that delay in diagnosis can create significant sequelae from a neurodevelopmental standpoint. We have antiviral therapies, and we know that neurodevelopmental evaluations are sometimes required in a much more comprehensive manner to truly identify what's going on. On the same time, we have the counterpoints for why we wouldn't necessarily screen all babies in the United States or even throughout the world. Most infants with this infection are asymptomatic. This could lead to overuse of antiviral medicines, undue parental anxiety and understanding that their infant has an infection and we don't know what might be the sequelae from that, the cost issues of rolling this out to all infants, the ethical concerns of knowing an infection's there and not necessarily understanding clearly what to do about that, and just meeting the true RUSP paradigm. So when we talk about universal congenital CMV screening, a couple factors come up in how we've moved through our research and how to identify and what might be the most feasible solution for looking at which babies may have CMV. We know there's a significant importance to the timing of specimen acquisition. Most infants are discharged by 48 hours of age. And in fact, even during COVID, many infants were discharged at 24 hours of age. So that this needs to be a specimen that's easily collected, often as part of the standard work that's already undertaken. And that leads us to the options for diagnostic testing, including dried blood spots, which all infants have collected around 24 hours of age for newborn screening, urine testing, which has been the gold standard for identifying CMV, as well as saliva, which we know has high sensitivity. Early efforts using dried blood spots were not prospective or population-based. We were looking back at stored spots. And then the CHIME study, which really looked at this several years ago, looked at dried blood spots and found that at that time, insufficient sensitivity for using screening was present, only about 30% sensitive on that dried blood spot. Saliva PCR demonstrated a much higher sensitivity in that study of 34,000 subjects, nearing 97 to 100%. And so really saliva has been a focal point of discussion in newborns and looking at that. However, we point out that adding a whole nother workflow with another both collection mechanism, training of staff, and having a whole nother testing platform for all babies really does pose different challenges throughout universal screening. So we looked at, well, could we improve the way that we use a dried blood spot? And we know that there's been improved DNA recovery methodologies described in recent years, improved extraction buffers for DNA, and increased sensitivity of PCR techniques and platforms, which created the work for the Minnesota Universal Congenital CMV Screening Study, or the Minnesota study as called at many of the CMV meetings. The hypothesis here was, does improved methodology translate into better sensitivity for the dried blood spot PCR and support reconsideration of looking at the dried blood spot as a tool for universal screening? And we compared analytic sensitivity of saliva and dried blood spot for CMV detection in a prospective population-based study in Minnesota. So initially we started our work, and the red highlighted arrows, as you'll see, are the mHealth sites at the University, Southdale and Ridges, and then quickly added on sites at both Minneapolis and St. Paul Children's in a partnership across health systems in the Twin Cities, and have recently added on St. Cloud as an additional testing site with now 6 hospitals participating in that data collection. And in this partnership, we have collected saliva swabs prior to hospital discharge. At the time of this analysis, recently published, we had 12,554 babies, which represented about 70% of those approached. They underwent a mouth swab with the Puritan polyester tipped applicator prior to hospital discharge, and then DNA was extracted using PCR primers. We ended up with 6 punches from the dried blood spot, and 3 went to the University of Minnesota and 3 went to CDC, as well as the standard newborn screening going to the Minnesota Department of Health, in which we could then perform PCR. Out of anyone that was identified positive via PCR, they underwent confirmatory urine, ideally less than 21 days. All of the other testing listed here, blood, audiology, ophthalmology, head ultrasounds. We enrolled them if interested in our long-term neurodevelopmental follow-up study. and made sure that their disease category classification was updated appropriately based on this testing. What we saw in these numbers are that the demographics of the study population of those 12,000 were quite similar to the population of Greater Minnesota. We did see that the parity of the study was trending towards smaller families, which we see throughout the birth rate in Minnesota. This is important, however, in that screening for CMV, we expect there to be higher rates of seropositivity with other children at home. And then most importantly, looking at the performance of the dried blood spot versus saliva. In this 12,000, more than 12,000 babies, the saliva sensitivity approached 93%. But importantly, the dry blood spot sensitivity approached 86%. And this is significantly higher than we'd seen in previous studies looking at 30 to 40% sensitivity with enhanced mechanisms. We also saw that the viral load distribution in saliva was wider with more trend towards false positives, and that the dry blood spot had a narrower window of viral load distribution. So in summary, we ended up finding that out of these 12,554 babies, we found 56 cases of confirmed congenital cytomegalovirus at a rate of 4.5 per 1,000. So as we expected for rates of CMV in all infant populations, the dried blood spot sensitivity was up to nearly 86%. We didn't find any relationship between viral load and symptoms, but did really call to question that dried blood spot may be a viable strategy for CCMV screening with ongoing refinement of these PCR techniques. This was just recently published in JAMA Pediatrics March 1st, if you want more information on what we're looking at here. In terms of what we found on how these diseases were classified amongst this first 12,000 patients, we did see about 75% asymptomatic, but important to note, 5 of those infants, almost 10%, did have some form of sensory neural hearing loss throughout that window. This brought us to the next question, which really, when thinking through, would you screen universally for CCMV? The question becomes, in these asymptomatic patients, does it matter if we know that they have disease? Are there long-term outcomes? And really, do we understand the neurodevelopmental sequelae of this infection? So we sought out to determine whether there are neurodevelopmental deficits in infants with asymptomatic CMV, and have assessed these infants who were members of the universal screening study, met the criteria for asymptomatic infection, and then approached for enrollment in our trial at 12 and 24 months of age. We had all these babies undergo event-related potentials, or ERPs, via EEG technology, underwent delayed response tasks, looking at working memory, Mullen scales of early learning as standardized developmental tests, and then MRIs at 12 and 24 months. This is an example of the EEG net cap that we use for ERPs. This test subject happens to be someone important in my life, my son Thomas. He is one of our healthy controls in other studies, but just you can see that there's really a non-invasive method for measuring EEG. This is a cap that goes right on their head, well tolerated, and ends up being a way that we can collect event-related potentials. Many people aren't familiar with what this technology is looking at, but ERPs represent activity of large populations of neurons that are simultaneously activated. So electrical signals propagate to the scalp, and this results in a series of positive and negative deflections on the ongoing EEG. The P300 component is a widely used measure of cognitive function in the area of the EEG, where neurogenerators are widely distributed, including the prefrontal cortex and the temporal lobe. And we see that decreased amplitude at the P300 component and longer latencies, longer time to get to the stimulus, are found in populations with diminished white matter integrity. What we do is we elicit an oddball stimuli against a background of repeating stimulus. So something very novel comes after repeatedly hearing the same tone. And then we repeat the shift. We expect this to represent a shift in attention to a distinct stimulus in an intact white matter. In the congenital CMV study task, we used 300 tones, about 15% of them at a higher frequency, so it should be novel to the subject. And they wear that sensor net and literally just play with toys while the tones are presented. What we expect to find in ERPs of novel stimuli and intact white matter is that you'll see a higher amplitude and a short latency to that stimuli. Whereas in the clinical case, we tend to see less difference between the novel and the expected, and a little bit of a lag in that latency, a slower time to get there. But on top of as this ERP, as we were analyzing this, we noted some pretty striking differences in EEG background activity when we looked at our first 12 infants who completed the 12-month EEG assessment. So the data was collected using that sensor net that I showed the picture of, and the EEG was analyzed using the standard NetStation acquisition software. We used an experienced pediatric neurologist who is familiar in reading EEGs, and looked at what is the background activity in awake non-task related segments. So meaning that the child was not asleep, but not actively engaged in activity. And we saw some striking differences. And so looked at these differences in subgroups using the statistical analysis provided. And what we found was pretty striking and quite unexpected. Even though none of these first 12 infants had any findings on their head ultrasound consistent with symptomatic CMV, they had no other developmental concerns known. We found that 11 out of 12 had the exact same pattern of delays in maturation on their EEG waves at 12 months of age. So in panel A, we see an EEG segment from one of our asymptomatic CMV patients. And after the red arrows, you see these lines that represent a frequency of about 4 to 5 hertz. This is in comparison to our healthy controls who are about 12 months of age, and behind these red lines have a background hertz of approximately 7 to 8 hertz. Now, for those that aren't skilled in EEG reading, what we expect is that a normal maturational pattern heads towards this 12 month of age. And these babies were all at approximately 4 to 5 months younger than expected in their maturational pattern on EEG. Importantly, we saw no seizures, no hemispheric differences, other things that would explain diffuse background differences or abnormalities, but we did see this consistent pattern of delayed maturation. We also then looked at, is there any difference when we treat patients with antiviral medications? And even though these babies were asymptomatic, several were treated for a variety of reasons with antiviral therapy. And although we did not approach statistical significance at the difference between treatment, you can see the black dots represent the healthy controls and their frequencies up higher at the 7 to 8 as expected in 12-month-old infants. But the asymptomatic patients that were treated in blue and then untreated in red did approach a trend towards the untreated patients having even the lowest frequencies or the least mature background in the EEG technology. So we have identified a novel finding of delayed brain maturation in these babies who were previously expected to be asymptomatic. We know that early identification of these abnormalities is clinically important for long-term neurodevelopmental outcomes. But really right now, the ongoing research is asking the question, are these changes going to persist throughout time? Or will this be something where the maturational changes catch up in later childhood and be of less consequence? If they do persist, this really would redefine the paradigm of what we previously thought of as asymptomatic infection. We're also undergoing other neurodevelopmental assessments, looking at working memory tasks called delayed response, where we hide a toy in one of 2 wells and then impose a delay and then ask the child to find it, which is an established marker of frontal cortex function. We're looking at some standard scales of early learning, and then brain MRIs. And interestingly, also in this first segment of 12-month brain MRIs, and thanks to Igor Nestersil for these images, we found that several kids fall in this category. This is a 12-month-old who had axial T2 weighted imaging, again, no expected abnormalities, and we saw hyperintensities in the white matter shown with the yellow arrows. Again, it remains unclear if this is actually sequelae of the CMV infection versus a delay in myelination that may catch up, but our 24-month MRIs hopefully will continue to answer that question. I do want to shamelessly call out that 3 of these abstracts are being presented at PAS on Saturday, May 1st and Tuesday, May 4th. If anybody's interested in learning more about the ongoing work with universal screening or the ongoing work with neurodevelopment surrounding those kids. And then just shift gear briefly into something that I did not expect to get as excited about, but really have as we've looked at this universal screening work. And these are slides that were presented to the Minnesota State Legislature. There's a bill in the Senate right now called the Vivian Act that was just presented in March. And these are all here in the state of Minnesota, families who are affected by children who had congenital cytomegalovirus, who have really formed a robust advocacy community in really asking for ongoing changes in education, screening, and then treatment of CMV for their children. And so this bill SF 1698 is called the Vivian Act, really brought forward by Vivian's mom, who is a 7-year-old now with congenital CMV and resultant sequelae from that, and really hoping to reach the 400 plus Minnesota families that are affected by congenital CMV every year. Here is some of the information that they are looking at. The Vivian Act is really calling for education of women and families and their providers as well, to really ask, why is CMV the most common viral infection that you've never heard of? And we hear that time and time again from the families who have been very passionate about advocacy in CMV, is that we know that this infection affects 1 in 150 children, and yet many, many women, once we tell them about the infection, have never heard of this. And in relation to awareness versus incidence, it's really pretty striking. This is another slide from the National CMV Foundation, and really reported as they looked at this, about over 90% of women have never heard of CMV, yet our annual incidence approaches that of Down syndrome. Whereas we take time to educate many pregnant women about kitty litter and congenital rubella and all these other things that have far, far less incidence, there's really no standard education program for women about cytomegalovirus. The Vivian Act is hoping to spread education to Minnesota moms to have a chance to reduce their risk. And many people, these are very, very simple things that they just want to be added to the education requirement. Avoid contact with saliva, kissing a child, putting a pacifier in the mouth, using the same utensils, sharing a toothbrush, and washing hands after diaper changes. Really pretty simple stuff, but it's amazing how many women, when you call out those steps, that I wish I would have known that when I was having, especially my second pregnancy, especially with a toddler at home. And so the Vivian Act has been brought forward under the leadership of Senator Karen Housley, looking at education and prevention. But interestingly, there's been lots of questions thus far about some of the work that we've done with universal newborn screening, looking at should some of these steps be combined together. But I also want to call out that some of what they're listing here at step 3 is another really important part of what we have looked at here in Minnesota. And that is the step towards vaccination and potentially eradicating the need for universal screening or for some of the education required. And so the University of Minnesota has recently been accepted as a maternal trial site for vaccination. They're rolling out a vaccination on an mRNA platform, similar to some of the COVID vaccines that have come out that have had initial early success. And so we will be looking to recruit young women of childbearing age in the not too distant future. Women who are not pregnant between 18 and 40 will be eligible, looking at, could we vaccinate for CMV in a way that may actually make all of the other work at screening, diagnosis, and care be far less required. And so I just want to call out to Dr. Slice for the work that he's done with advocacy. I don't know that he ever expected to be doing this much work surrounding advocacy when leaving the virology lab, but this is a slide from the actual parents involved in the Vivian Act, and they have been very, very grateful for the ongoing work and advocacy in trying to understand what we might do as a medical community to help deal with the sequelae of congenital CMV. And then shifting gears just briefly. So what really got me excited about this work initially was, why do the population that I take care of in the neonatal intensive care unit end up with sequelae of CMV, even if they're not born with it, but when they acquire it? So certain at-risk populations we know are vulnerable to getting CMV after they're born. Postnatal acquisition of cytomegalovirus in preterm infants may occur in the postnatal period, primarily through transmission from maternal breast milk. Moms who are CMV positive can shed into the breast milk. In the majority of cases, at some point in lactation, if you've had CMV, you will shed into the milk. And most infections are asymptomatic in healthy newborns. We know that if you would probably never even realize that breast milk had CMV shedding, but there's a certain population of preterm, especially extremely low birth weight infants who are susceptible to sequelae of these infections. And this also happens in other immunosuppressed populations that we may take care of. So in preterm infants, there can still be asymptomatic infection, but there also is growing evidence of a severe sepsis-like syndrome in some babies, especially the very preterm infants between 22 and 26 weeks gestational age. Also, there can be associations with increased chronic lung disease, necrotizing enterocolitis, and secondary infections in very preterm infants who acquire CMV. So here's another clinical case of someone that we took care of. This was a 24-week gestational age male who was born at 800 grams, was admitted to the NICU. He actually had testing for congenital CMV that ruled out with a negative PCR on day of life 12, and then started breast milk feedings on day of life 14. A couple weeks later, day of life 26, he developed severe abdominal distension and concern for necrotizing enterocolitis, so was started on antibiotics. Blood and urine cultures remained negative, but on day of life 33, he had significant clinical worsening, thrombocytopenia down to a count of 24,000, and was quite hemodynamically unstable. So he underwent exploratory laparotomy that revealed multiple perforations in the jejunum, and an astute pathologist underwent histology testing that showed variable ischemic necrosis and on staining CMV inclusion bodies. So here's the surgical specimen from this baby showing viral cytopathic changes, and importantly in panel D, positive stain for anti-CMV antibody in affected cells, virtually confirming the diagnosis of cytomegalovirus in the intestinal tract. So he, after surgery and after the pathology return, confirmed systemic CMV infection by urine and blood PCRs. Was started on ganciclovir on day of life 35, given the severity of that illness and the sepsis and end organ involvement, and eventually underwent ostomy takedown and bowel reanastomosis. However, really had severe sequelae of chronic lung disease and neurodevelopmental delays at the time of discharge with ongoing severe illness. So acquired CMV in the preterm infant is a complex and difficult condition to treat because we know that there's a multitude of benefits of maternal breast milk in preterm infants. So the risks of withholding breast milk to avoid postnatal CMV are quite high and generally not undertaken, although there are some countries, especially notably Germany and France, which have taken to pasteurizing even mom's own milk if she's CMV positive. That's not been a standard approach in the United States. But we know that long-term neurodevelopmental outcomes of preterm infants who end up with acquired CMV aren't completely clear, but definitely concerns of adverse impact on intellectual development have been raised. There's little data on the pharmacokinetics and pharmacodynamics of valganciclovir in preterm infants. So throughout treatment, there remains concerns for side effect profiles. So we asked the question to be able to better understand acquired CMV. We looked at a study of preterm infants within the NICU and asked to determine what is the prevalence of CMV DNA lactea, meaning how much DNA gets into the milk. What's the rate of transmission of acquired CMV into the baby, DNA emia or bloodstream? And then what are the potential symptomatology in a cohort of very low birth weight infants? So we enrolled 200 infants in a prospective study of babies less than 1,500 grams in the NICU at the University of Minnesota. If infants had congenital CMV, they were excluded, and then collected weekly maternal breast milk and whole blood samples. And we were actually able to consent this many infants by collecting whole blood as waste blood, just the additional blood that's taken from other clinically indicated samples. The lab would hold on to us, and we were able to do PCRs on just very small amounts of whole blood in those babies. So we had breast milk samples from 164 of the moms. This represented 184 of the babies. If moms had low supply or ended up not having as much breast milk, then that milk all went to babies. That's where the 184 came from. And the prevalence of this DNA lactea was calculated out of all moms providing milk rather than out of 200. So 153 out of 184 infants then also had corresponding blood samples. About 83% of our whole sample had blood and milk matching up throughout the time frames. We then analyzed with paired mom's milk and infant serum, looking at how this transmission happened, potential infectious symptoms, and whether the infection was clinically recognized. What we saw in the acquired CMV cases are that the prevalence of DNA lactea in the milk from all the moms is about 40%. So 65 of the 164 ended up shedding into milk, and the peak viral lactea was in about 6 weeks postpartum. So this is weeks postpartum, the milk load went up, viral load of DNA, and then gradually went back down at this point. And the rest of the results for the babies, there were 49 moms positive for CMV in the milk. And then we had the matched blood samples for those infants for 58. So 40 singletons and 9 twins. Of the babies exposed to CMV in the breast milk, there were 8 infants identified with viremia, or 13% of babies. Interestingly, clinicians were unaware and had not tested for acquired CMV in 5 of 8 of those cases. And on further analysis, it was noted that several of these infants manifested some symptoms that were likely related to acquired CMV, but were generalized illness symptoms without recognition of the infection by the care teams. So all 8 of those infants were diagnosed with CMV, were discharged with a diagnosis of chronic lung disease, which is quite significant at 100%. 3 infants had unexplained thrombocytopenia. 5 of those infants actually had sepsis-like illness, and really only in 1 of those 5 had clinical recognition of acquired CMV as the cause of the sepsis illness. And so what we see here is just a chart of all of the infants that ended up having CMV viremia and generally ended up trending towards younger gestational age babies. The viral load in the milk was across the board. We really didn't necessarily have one symptomatology associated with higher viral load. In fact, we had sometimes more symptomatology with lower viral loads. The day of life that they ended up becoming viremic was somewhere in the 40 to 50 range for the vast majority, which does potentially clue in clinicians to when they should be looking for this infection. And then the complications as listed, different gram-negative infections, associated bacterial infections, sepsis, thrombocytopenia, again, not entirely related to their CMV disease, but did seem to be concomitant to the time that we noted increase in viral load in the baby. Interestingly, only 3 of the 8 were suspected as diagnoses in terms of clinicians looking for CMV infection. And this would be interesting even across the United States, as the center at the University of Minnesota tends to look at CMV more often than some other places. So this really asked us about some of the unanswered clinical questions that we have throughout all of this work. And as we have identified studies through universal screening and neurodevelopmental outcomes in the preterm infants, I think we've ended up with more unanswered clinical questions than we have answers. And here are just a few that we'll be looking at in the future, really looking at what do we do with the infants who are recognized after 21 to 30 days of life, and we don't really know whether they have congenital infection or acquired infection. Should they go through the 6 months of treatment with valganciclovir that's recommended in congenital infection? What are we going to do with these mild or asymptomatic congenital infections? Should they be treated, especially looking at sensory and neural hearing loss? Do we screen all infants or even all preterm infants to know about their congenital status at the time of delivery? How long and long-term outcomes of preterms with treatment, and even the effects of the medications that we're using to treat them? I think one of the big parts of both the advocacy work and now the vaccination work is that we realize we maybe need to step back and move one step forward before we actually deal with treatment of an infection and talk about what are the best strategies to prevent maternal infection or reinfection during pregnancy. And very likely maternal vaccination before pregnancy seems to be the most plausible mechanism that we will gain true improvement when it comes to dealing with this viral illness. And we're really excited to be a part of that work going forward. So with that, I'd like to acknowledge lots of people that have been very, very helpful and essential to do this work going forward. Our team at the University of Minnesota and the Center for Neurobehavioral Development has really made this work possible. And then really our co-study teams at the CDC and the Minnesota Department of Health have been essential for helping us get the universal screening work moving forward, and then the long-term neurodevelopmental outcomes. So with that, I'd be open to taking questions and really thank you for your attention.
All right, thank you very much. That was excellent. We do have some questions coming in, and for our attendees, as a reminder, you can use the Q&A or the chat. This one comes from Steph. It seems that with the newborn screening data that the good of universal screening far outweighs the bad. Where is the process of adding CCMV to RUSP at?
So this is actually an exciting question because it's rapidly evolving. The Vivian Act came to the Minnesota State Legislature March 4th, and it was expected to be an understanding of the educational components for both medical providers and women. But now there has been lots of question about whether the state of Minnesota should look at financing universal screening. And so some of those aspects of the bill are actually being incorporated and moved forward. And that discussion is a little bit longer than the scope of this talk, but really it's been exciting to see that some of this work is actually moving forward much faster than we anticipated. And you may actually hear even within the next year of time about much more expansion of universal screening.
Great. Yeah, and there's sort of a similar follow-up question, just asking about, now that the dried blood spot, that we have some of the evidence that you shared with us about the accuracy for identifying CMV infection. I think just another attendee wondering about universal screening for all dried blood spots. So it sounds like we're working on that locally.
We are, and I think, so the RUSP is across the entire United States also from the newborn screening panel. There have been efforts in other areas, especially in Canada, to use universal screening with saliva. I think that we're really hopeful that we won't have to add another workload to our nursery staff across the entire country to have a different specimen collection, a different lab platform, and all the costs associated with that with universal screening. So we're really hopeful that the dried blood spot can be an answer with enough accuracy. But I'd have to say, you'll have to invite Dr. Slicer back in the next year or two to update on this.
I'm not sure, Dr. Dobbins maybe wants you to just comment a little further on just why so many moms who are CMV positive end up having babies who are CMV positive.
Yeah, so this is a really good question. I think something that we've understood as we have more screening. So about 1% of moms who have previous seropositivity will have a infection, what we used to call a reactivation in pregnancy. More and more research has been done that actually shows this is probably not reactivation, but reinfection with a different strain of CMV, which has made CMV very difficult to truly get on top of with some of the other vaccine mechanisms that we've looked at in the past, in that when we have variant strains, as we're familiar with in other illnesses at this time, people can get infected with that, and their previous seropositivity doesn't necessarily provide full protection. So out of that 60% of women that are seropositive, we estimate now about 1% of those women still have babies with CMV. And just at a population level, that's a much, much larger number than the smaller percentage who have a transmission rate at 30 to 40%, but only get infected 1 to 2% of the time. And so that really ends up kind of shifting the paradigm that we used to think you're only susceptible if you've never been infected with CMV. And I would love to have a way to reassure moms, oh, if you've already had it, don't worry about it. Our ongoing data, or the data across the country, would say that that actually, unfortunately, is not true, that you still need to be prepared that reinfection with another strain can, in fact, lead to newborn illness.
Yeah, thanks for that clarification. This question comes from Megan Paulson. Thank you, Erin. What a fantastic example of integrating research to advocacy and policy to improve health outcomes in our state and beyond. For the preterm infants with positive CMV in the last study you spoke about, is there information about, number one, mom's symptoms, and number two, whether this is a primary or maybe not reactivation as you just stated, but is it a primary or a repeat infection in mom?
Mm-hmm. Yeah, that's a really good question. And we don't have perfect answers on that, but what we do know is that most of these that are a reactivation type in the breast milk that we see as a very complex phenomenon after pregnancy, likely with the immune suppression that goes along with maintaining fetal life, we see that many moms reactivate the CMV into their breast milk without clinical symptoms of infection. So that most of these moms do not have an illness or something expected with a primary CMV infection. And it's expected that most of those go on to just reactivate at the mammary glands. It's been somewhat still difficult to understand. And I don't know that we have a perfect answer, because we're just learning more about acquired CMV really in the last several years.
Thank you. Yeah, I think this idea of reinfection versus reactivation has got a lot of people thinking in the audience. So another question, how you would try to sort that out, basically. They say, is there any test for reinfection or reactivation? I understand IgM is not always positive in reinfection or reactivation.
Right, both of those are true. And right now, I think it's a complex question that really has to do with when they've been able to identify the strain variants. And so that's something that's not commonly done unless you are actually doing PCR and then culturing the CMV. But that work has been done at a more bench level to help identify that these were likely actually different strains of CMV. And so at this point, there isn't going to be a standard clinical test for women to say, I've been reinfected versus reactivated. And at this point, we don't know that there's really any clinical sequelae that would matter for us. We don't routinely try and culture the virus out of different aspects for women.
Great, thank you. Kind of a general question about the natural history of CMV. Until what age can the hearing loss from congenital CMV occur?
So we expect the highest rate over the first couple of years of life into age 2. But we do see some children that still have ongoing hearing loss in the early childhood, 3 to 5 years, but really the expected worsening for hearing loss when identified in congenital disease, that 10 to 15% that will progress, generally expected to be the highest incidence in the first couple of years, which is why we recommend the audiology follow-up at 3 to 6 month intervals during that highest risk time so that we can get on top of that progression early.
Great, thanks. That's probably a really good reminder for those of us in primary care to not get lulled into complacency by a past hearing screen in the newborn period, because it means they passed when they're newborns, but if their speech is not developing as expected, check it again.
Absolutely, Emily. I sound like a broken record with the residents sometimes. I'm great. I'm glad that they passed their newborn screen, but please make sure they get scheduled for their audiology follow-up.
Erin, how early do you think, or do we know how early you see the ERP and EEG findings? And do you think that earlier characterization of that might be beneficial for prediction of anything?
Yeah, it's a great question. And I think the honest answer is we don't know yet, because we did not truly expect to find changes at 12 months on these asymptomatic patients. I think we were hopeful that we could say, yes, there really aren't changes in these patients, or they're very subtle. And now we have seen changes that we probably do need to go back and even think through, when do we need to evaluate these kids at key intervals? Is it actually 4 months and 6 months? And some of the time where we're also looking at other neonates at risk for other findings. And this time we don't really know. We have these patients at 12 months and 24 months, and we know we're seeing changes, but we might end up needing to look earlier too.
We have I think you alluded a little bit that in Canada, there's some momentum about universal CMV screening, but one of our attendees is just wondering about programs across the globe and other people who are looking into CMV.
Yeah, so Ontario has rolled out universal saliva screening, and I am hoping to hear more updates about that as we start returning to our national meetings post-COVID. But they have rolled out a salivary program. There are others that are looking at this across the United States as well. I don't know of any programs that are up and live right now. So many are waiting for what they term the Minnesota data to help guide some of the universal screening plans across the country. There may be some that I'm just not aware of, but.
Wonderful, thank you very much. Dr. Georgieff did mention in the chat that the changes in the ERP tend to predate some of the behavioral changes or things that you might be able to observe in a child's behavior or development. I think we have time for this one to close it out. Asking about moms who are seropositive. Is there any talk about a routine PCR test or some other screening for pregnant women as an investigation for reactivation or reinfection?
I don't know of any of that at this point in time. I'm not sure of that. I think really where most of us are the most excited about our vaccination strategies to avoid needing to worry about those infections during pregnancy, and really from a global population level, a much more sound practice to really actually have that improvement would be to focus at the level of vaccination. And because we're seeing promise with an mRNA platform for vaccination, we're hoping that that really won't be something that's in the far future, but actually in the near future.
Wonderful. Thank you so much. Thank you everyone for your thoughtful questions and for your attendance. Have a wonderful week. Thanks, Dr. Osterholm.
Thanks, everybody.
Thank you, Erin.